Hello and welcome to ICOS Bubble TV. I'm Robin Adams and I'm joined today by one of the leading experts in the field of contrast enhanced ultrasound and contrast microbubbles, Dr. Stephanie Wilson. Stephanie, thank you for joining us this morning.
My pleasure.
Perhaps we could start by asking you to say a little bit about yourself, where you're from, and what type of practice that you have.
So I'm a Canadian, I'm a radiologist, and I have been involved with microbubble contrast agents now for over 20 years. And so it was in about the year 2000 that we performed the first patient trial in North America injecting microbubbles into patients. And our objective was to look at masses in the liver. And since that time, I have worked really fully immersed in microbubble imaging. And so I was in Toronto until the year 2007, following which I went back to my home in Calgary, in Alberta, in Western Canada. And that venture has been a very, very successful venture. At the time of my arrival, they did not use ultrasound much for imaging liver masses, and they didn't use any microbubble contrast agent. And now we are the biggest user of microbubble contrast agents for imaging the abdomen and especially the liver in North America. And so this has proven to be very successful. It's a wonderful technique. Patients love it, and this is a safe and easily performed technique with great patient benefit.
So we're here this morning to talk about microbubbles. Perhaps you could tell us a little bit and explain bubble basics for our viewers.
So when we do a contrast enhanced ultrasound examination, we inject a minuscule amount of fluid, and this fluid contains tiny, tiny bubbles of gas. And so these bubbles of gas travel in the circulation, and then when they arrive, for example, in the liver, the bubbles will enter the liver and they will enter the tumor or the mass that we're looking at. And so when the bubbles travel in the circulation, if we put an ultrasound probe on the body over that area, this will cause an ultrasound wave to go into the tumor and the liver. And when the ultrasound wave strikes the bubbles, it will cause the bubbles to change in size. And when they do change, so the bubbles are changing bigger, smaller, they emit a very strong signal. And so this signal is greatly enhanced over the normal signal that we would get from the blood. And so it allows us to obtain just exquisite visualization of all of the places in the circulation where the bubbles go. So it gives us a picture really of the microvasculature of the liver, and more importantly, the microvasculature of the tumors that we see. And we know that cancer, for example, looks different than a benign tumor. And we know that the tumors look different than the liver. And so the diagnostic capability afforded by this very tiny injection is really astonishing.
You obviously use microbubbles quite a lot, but how often and when would you use microbubbles and why?
So the two major groups of patients that we scan predominantly by choice is the liver. So the liver has become a very, very interesting organ for study in that both hepatitis B and hepatitis C cause chronic liver disease. And so this has been known for a long time. However, more recently, we now live in an era that's called the obesity epidemic. And so with the obesity epidemic that we're undergoing in North America is associated fatty liver. And fatty liver also causes cirrhosis and chronic liver disease. And so today that is becoming the most important cause for development of liver cancer. So this is something that's escalating in importance. So we look at the liver, we look at tumors, and we're very, very capable of the evaluation of these nodules as they change from benign cirrhotic nodules into liver cancer. So that's one of the main things that we do. But a second arena that we work in a lot is inflammatory bowel disease. So this is looking at patients with Crohn's and colitis, a very important problem in North America, in that this is a chronic disease and it causes inflammation of the bowel that's lifelong. So people that get this disease in childhood or adolescence will have it for their entire life. It's characterized by episodes of inflammation and remission. So when the patients have episodes of inflammation, it's important for the doctors to be able to determine how much inflammation there is in the bowel. So we look not only at tumor vascularity, the microvessels in a tumor, we can look at the microvessels that are in the bowel wall, and they increase as the inflammatory process gets worse. So we do assessment of inflammation and scarring in the bowel in patients with inflammatory bowel disease. Now, why is this important? It's very important because previously this was the domain of CT scan. And so of course, if you have a small child with Crohn's disease and they're going to have this for the next 20, 30, 40, 50 years of their life, we don't want to do a CT scan on them twice a year because of the radiation risk. And so the great thing about the imaging with microbubbles is not only how well it can see the microvascular structure throughout the body, but it can also do this with no requirement for any ionizing radiation. So it's a very safe technique.
So it's fair to say that this is probably one of the key reasons for using SEERS and microbubbles instead of some of the alternative imaging options.
Well, I would put it a slightly different way. This is a reason for not using CT. The reasons for using microbubbles include that, but include more importantly just the unique capabilities that we have with these tiny bubbles to provide such great information about the vessels.
And just following on from what you've been saying, do you have any specific examples where SEERS has made a real difference to your patients?
Oh, every day. Now, many of the things that we find, because we're always hunting for tumors, so we find bad things, but nonetheless, patients who do have problems with a cancer or with any kind of tumors in their liver, they are so relieved and very happy always to have an answer that turns out to be the correct answer. So it's a very accurate, sensitive technique when it's applied within the oncology population. But it's also very, very beneficial, for example, incidental liver masses. So these are masses that are found on any imaging test or even palpating the abdomen. The doctor may feel a mass in the abdomen. And so many of these incidentally detected masses, previously they would have first a CT scan and then an MR scan for their diagnosis, whereas we can now diagnose most of the things that you feel within the abdomen or identify with the microbubble technique. So it's more available, it reduces the wait time for the patient, which is a high anxiety time until they know what the mass actually represents. And as many of these masses are in fact benign masses, so these are masses that develop in any of the solid organs or even the bowel, but many of them are not cancers, and so we can identify those equally well, putting the patient's mind at ease at a lower cost and a lower wait time, so it reduces both anxiety and cost.
And cost. And I would guess this has had an impact on the hospital workflow as well.
Absolutely. So from a hospital's perspective, there's many reasons for supporting an ultrasound contrast program. So the first one, of course, is that the hospital administrations have a responsibility to their patient population to reduce their exposure to ionizing radiation. So that's a major feature for the hospital. A reduced capital outlay and operational cost is another reason to favor ultrasound over more expensive modalities. And patient satisfaction, of course, is a very major one as well.
Absolutely.
Now, in addition to that, there's another population that's important. So in the United States and Canada, in North America, there are many, many, many patients with renal failure. So their kidneys are compromised. And as soon as your kidneys are compromised, you cannot have either CT or MR contrast agent. And so another great thing about using microbubble contrast agents is that it doesn't even matter if there are kidneys. It has no effect. We don't need the kidneys to do the scan. They don't excrete the contrast. And it's completely safe to do that population. And so what happens today in hospitals that don't do microbubble contrast agent, if a patient arrives for CT or MR scan, they check their kidney function, and if it's abnormal, then they convert the scan to a CT or MR scan with no contrast. And of course, CT and MR scan are completely reliant on the contrast agent to make their diagnoses. So a much better step would be to convert that more expensive scan to a less expensive CUS exam, where we don't cause any nephrotoxicity, no problem for the kidneys, and the diagnostic output is very, very similar.
Very interesting indeed. Let me just wrap this up by asking you for a few brief comments on where you think the field is going over the next year, 5 years.
Well, my hope has always been, I'm on record for the last 20 years of saying that I do believe that ultrasound with microbubbles should be the screening test of choice for looking at patients with inflammatory bowel disease. I think it's superb. Now, in the liver, which is my other real passionate interest area, this issue of liver cancer has become of such paramount importance. It's one of the few solid organ cancers that is increasing in incidence in North America. And ultrasound as a regular component of the screening process and the continuous evaluation of liver nodules, I think we really have a great advantage to do that for similar reasons with great accuracy. So I really hope that ultrasound will be recognized and continue to grow in utilization. And of course, this is not always the easiest thing that happens, but I do believe it's of real paramount importance and a major contributor to those areas.
Absolutely. Dr. Stephanie Wilson, thank you so much.
Thanks, Robin. It was a pleasure to be here.